to the doctor in 2012 with a chronic cough that started after a flu infection. And the doctor wasn't sure what was wrong with me. There was a strong suggestion she thought there was maybe nothing wrong with me. She said, try not to cough. She diagnosed cough variant asthma with a big question mark. I went for the asthma test and my lung function was normal. It didn't indicate asthma, but I took the asthma medication, which was inhalers. It made no difference to my cough. When I went back to the doctor and said, I don't think I have asthma, I wasn't re-referred to the pulmonologist. I was referred back to the asthma nurses to work on my technique with the inhalers. I eventually stopped taking the inhalers because I didn't like the side effects and they didn't make any difference. And it was not until 8 years later, after the initial misdiagnosis in 2012, it was not until 2021, 9 years later, that I was diagnosed with bronchiectasis and a CT scan was done. But at that stage, even though I had the bronchiectasis diagnosis, I was still prescribed asthma inhalers, which I didn't take. And it was only because I went online that I found out that I should have been doing respiratory physiotherapy. I found out all kinds of other information about bronchiectasis, which was very helpful. And then I went back to a bronchiectasis specialist, and then I asked for the respiratory physio and various other things that I knew I needed. So for me, it's been a process of having to find out the information myself and then having to ask for it from the clinicians.
The last decade has seen a huge improvement in bronchiectasis care, and there's actually so much that we can do to improve the outcomes of patients with bronchiectasis. And GPs or family physicians have a very important role in diagnosing bronchiectasis, but you need to know what you're looking for to diagnose bronchiectasis. So to diagnose bronchiectasis, you need to first have a suspicion, and this would be raised by somebody who's coughing a lot, a long period of time, over months, chronically producing sputum, and has frequent lower respiratory tract infection. So if your patient is doing that, you have to refer to a high-resolution CT scan. You actually don't need contrast material to diagnose it. To diagnose bronchiectasis, you need typical symptoms plus the radiology detecting bronchiectasis. And it's important to note that bronchiectasis can be diagnosed in smokers as often as non-smokers, and don't exclude the possibility of bronchiectasis just because your patient smokes.
Rachel's story illustrates really nicely the common themes that we see in many of our bronchiectasis patients, which are misdiagnosis initially and a delayed diagnosis. In family care or primary care, we have a really important role in picking up patients with bronchiectasis and referring them for a high-resolution CT scan to confirm the diagnosis. If you have patients that have got a chronic productive cough, particularly if what they're coughing up is yellow or green, then you should definitely think about the diagnosis. Also, we have some patients that present with recurrent chest infections with no obvious other reason for that. It's worth recognising that a lot of patients are misdiagnosed with asthma or COPD initially, and they do have a complex relationship with bronchiectasis. So if you have asthma patients who, despite increasing treatments, don't seem to be responding, it may be that they don't have asthma, they could have bronchiectasis. If you have COPD patients who are exacerbating frequently, particularly if they're growing unusual bugs, then again it would be worth thinking about the diagnosis. But essentially, chronic production of sputum is not normal, and a cause or an explanation for that should be sought.